Good day, my dear students. Topic of today our lecture will be purulent diseases of the lung and pleura. Anatomy of the lungs. Lungs are the pair of respiratory organs situated in the thoracic cavity. Right and the left lungs are separated by the mediastinum. Texture: it's sponge. Color: young lung have the brown color. Adults mottled black due to deposition of carbon particles. Weight of the right lung is about 600 grams, left lung about 550 grams. Thoracic cavity consists from the thoracic wall, which include the ribs, the sternum, and the vertebral column, and formate the cage, and thoracic cavity. Both lengths are their heart. Pleural cavity, what consists of the parietal and visceral pleura, and intercostal muscles, taking the big role in the breathing movements. Fissures and the lobes of the lungs. Right lung consists from the three lobes. It is superior lobe, its middle lobe, and inferior lobe. Right lung consists of two lobes, its superior lobe and inferior lobe. And in the right lung there are cardiac notch and hilum. And now let's talking about semiotic of acute suppurative diseases of the lung. First of them, abscess and pneumonia. It's a multiple destructive foci by 0.3 till 0.5 centimeters in size within one or two segments of the lung. Second, abscess of the lungs. It's a purulent or ichorous destructive of pulmonary tissue with formation of one or severe cavities, filled by pus, and detached from adjacent parenchyma by a pyogenic capsule. And third, gangrene of the lung. It is diffuse purulent ichorous necrosis of the tissue without the tendency to demarcation, with prompts spreading of necrotic zone and destruction of the parenchyma. Etiology and pathogenesis. Disturbance of the bronchial patency with the development of atelectasis. Next, inferior inflammatory process in the pulmonary tissue. Regional disturbance of the blood supply with the future necrosis of the areas of pulmonary parenchyma is the main reasons of the suppurative diseases of the lungs. Symptoms and the clinical course. At first, symptoms of the lobar pneumonia. At second, symptoms of the intoxication, such as general weakness, headache, malaise, suppressed appetite, moderate chest pain, dyspnea, subfebrile temperature, throbbing, coughing, and dyspnea too. And sometimes can be coughing with the sputum. After the taking of the complaints, you have to take in the objective signs of this disease. After the revision, you have to follow the algorithm of the investigation of the patient and goes to the percussion. On the percussion will be blunted sound over the site of the purulent focus and perifocal infiltration at subpleural location of the abscess, for example. Next, auscultation through respiratory with the Moises rails in the zone of the purulent focus. After abscess discharging could be revealed bandbox sound by percussion, and on auscultation will be moist rails of the background or amphoric respiration. To prove your diagnosis, you have to prescribe observe X-ray examination. There you can see, in case of the lung abscess, big infiltrating shadow, sometimes without clear border. It is the stage of the formation of the abscess. Stage of the breaking through, when the portion of the pus evacuate from the abscess, you will see the horizontal level. Pus can go to the bronchial tree and evacuate with the sputum during the coughing, or it can go to the thoracic cavity, to the pleural cavity, and forming the empyema of the pleura. Let me show you how it looks schematically. Pathomorphology of the lung abscess. At first will be formation of the infiltrate. Activation of the microflora happened because of different reasons, but will be formation of the infiltrate with purulent focus, formation of the pyogenic membrane around the abscess, and when the capsula will be ruptured, it can happen to the bronchial tree, how shown on this picture, or it can happen because the rupture of the parietal or visceral pleura. It goes to the thoracic cavity. After the draining of the abscess, patient have coughing with big amount of bad smell sputum and relief of many complaints can be there. Can be decreasing of the temperature, can be decreasing of the coughing, and decreasing symptoms of the intoxication. After, when accumulation of the pus will be increased and patient haven't drainage, clinic will be repeating, and the patient have fever, have intoxication again. On these pictures you can see how look in this situation on X-ray. Here you can see infiltrating shadow of the abscess, and here you can see capsula and level of the fluid inside of the abscess. On this picture you can see round shadow with the horizontal level too. It is a side X-ray. Here you can see the shadow of the heart, and here you can see the shadow of the abscess. It's very important to make the correct differential diagnosis of the lung abscess with the central lung carcinoma. On this picture you can see the abscess with the horizontal level of the gas inside of the abscess, and here you can see the completely atelectasis of the right lung, because the central cancer blocking the passage of the air and lead to the formation of complete atelectasis of the right lung. On next pictures you can see differential diagnosis of the lung abscess with the peripheric lung carcinoma. Here you can see the lung abscess with accumulation of the gas upper than the pus. Here you can see the carcinoma. You haven't find here the clear shadow, clear border between the pathologic tissues and not involving pathologic process tissue, and there is no any horizontal levels. Next differential diagnostic can be performed with the lung abscess in infiltrative or pneumonia stage with the tuberculosis. In this case, you can see multiple shadows on the both lengths without clear focus. On these pictures you can see differential diagnostic of the lung abscess with the tuberculoma. Here is the tuberculoma with the small calcification shadows. Here you can see the formation of the lung abscess in pneumonic stage on infiltration stage without any clear horizontal level. Complications of the lung abscess are the pulmonary bleeding, pneumothorax, pleural empyema, sepsis, and the bronchial dissemination. Pulmonary bleeding has 3 degrees. First degree, it's hemorrhage less than 300 milliliters. Second degree, hemorrhage less than 700 milliliters. And the third degree, hemorrhage exceeds 700 milliliters. Treatment: at first, stopping of the cough. At second, decreased the pulmonary blood pressure, and finally hemostatic therapy. Pneumothorax you can see on these X-ray pictures. If the drainage of the abscess don't happen to the bronchial tree, it can happen to the pleural cavity, and all fluid are going there and accumulate with formation of the empyema and sometimes with the atelectasis of the lung. Tactic and choice of treatment. At first, the adequate antibacterial and anti-inflammatory therapy. Second, evacuation of the purulent content of the cavities. Active sanation of the tracheobronchial tree or repeated puncture of external drain of the peripheral cavities. And third, detoxification therapy. Sometimes for prolonged tracheobronchial lavage, this patient need to formation of tracheostoma. Next, immune correction, desensibilization, anti-inflammatory therapy, regulation of activity of the protease. You can use antihistamines, non-steroid anti-inflammatory agents, inhibitors of the protease, antioxidants. At least you can use correction of the dysfunction of the vital organs and systems, prevention of the complication, symptomatic therapy. Indications for operative management in acute destructive process of the lung. Pulmonary bleeding of the second and third degree. Progression of the process of the background of active and appropriate therapy. Tangent pneumothorax, which is failed to liquidate by the drain of the pleural space, and impossibility to rule out the suspicion of a malignant tumors. Contraindications: decompensation of the vital function in the terminal stage, bilateral purulent destruction of the lungs, concomitant incurable malignant tumors too. Next condition is thoracic empyema. It's accumulation of the pus in the pleural cavity. It comes from the Greek word empyen, which means the pus production separates. Pleural empyema is the purulent inflammation of the visceral and parietal pleural membrane, which is associated with the accumulation of the pus in the pleural space. Here you can see the accumulation of the pus with a not clear shadow, and same situation you can have here. Etiology and the pathogenesis. It is a purulent and destructive process of the lungs. It can be abscesses or another inflammatory process of abdominal cavity, such as pancreatic necrosis, for example. It leads to the secondary pleural empyema. Open and closed damage of the chest can formate the empyema too. And the operative approaches of the thoracic organs, primary empyema. Secondary empyema can occur in 88% of the patients. Classification of the empyema. At first, according to the pathogenic factors, it can be primary or secondary. At second, according to the clinical course, can be acute and chronic. And the last, according to the extension of the process, it can be focal or widespread. Clinical manifestation, it's the pain, dyspnea, cough, intoxication. By palpation, you can see diminished vocal fremitus on the side of the lesion. By percussion over the exudate, it is possible to relieve short sound. By auscultation will be diminished or absent sound. If you will take in the analysis of the empyema fluid, you will see the alkaline pH. You will see glucose level less than 40 milligrams in deciliter. You can see a lot of the leukocytes and a big level of the protein. Tactic and choice of treatment. The presence of the pus in the pleural space is the indication for its elimination. In the place of the performed diagnostic thoracentesis carried out the drain of empyema's cavity, its sanation by means of antiseptic solutions. In a focal empyema, the aspiration of pus is performed by the thoracentesis and only it in its insufficiency carrying out a drain of pleural space. Intensive antibacterial and anti-inflammatory therapy. On this picture you can see where can situated the pus in the thoracic cavity. It is another picture where you can see atelectasis, small formation of the gas, and accumulation of the pus in the right thoracic cavity. On these pictures you can see what the focus of the purulent information situated in the half of the thoracic cavity with atelectasis. CT and MRI can be also useful for differential diagnostic of this disease. It shows you lymphatic nodes in mediastinum, can show you the place of formation of the abscess and place of the accumulation of the pathologic fluid, the pus or the gas was situated in the thoracic cavity. Here you can see the small portions of the gas what's mixed with the pus in the thoracic space. Now let's talking about the places for thoracentesis. Different conditions have different places for this situation. First place, it's second intercostal space by the subclavicular line. We can use it for pneumothorax. It's happened because of gravitation, because the air going up and lung going down. And if you do puncture in the second intercostal space, risk to making the trauma of the lung is the minimal. For hydrocentesis, it is the fifth or sixth intercostal space on mid-axillary line. Of course, because the gravitation, fluid in the thoracic cavity going down and lung going up because it contains a lot of gas. And puncture in this place decrease the risk of the trauma of the lung to the minimum. For pyothorax, we have to using most lower space. It's the seventh or eighth intercostal space on subclavicular line because we have to remove completely all pus contents from the thoracic cavity. Better to mark this place under X-ray or ultrasound control and performing the synthesis with aspiration of the pus and washing by the antiseptic solutions, and evacuate of all fluid completely from the thoracic cavity after all manipulations. Why it's so necessary to remember all these places? Because you can do the heterogeneous trauma of the patient. In this situation, you see the needle goes to the abdominal cavity, here will be situated the liver, and you will have internal bleeding after the uncorrect puncture. How this procedure looks? And first, you have to do infiltrative anesthesia of the region where you will do the puncture. You will use procaine solution 1/2%. And after, when you do anesthesia on the upper part of the rib, you have to do the puncture and go with the needle to the thoracic cavity. As you can see on the lower part of the rib, there are a lot of vessels, and puncture in this region can lead to the bleeding. Don't remember what pressure inside of the thoracic cavity are negative. That's why when you do aspiration, you have to using some tool to stopping the contents, because if patient breathing in, air through this needle goes to the thoracic cavity, and your pyothorax or pyothorax of your patient will transforming to the pneumothorax, and it is not a good situation for your patient. After the diagnostic puncture, you have to do thoracentesis. You using the trocar, doing the puncture. Through the trocar, you install the tube inside of thoracic cavity and fixing this tube to the skin. After that, you have to connect the tube with aspiration system and do aspiration of the air or fluid contents from the thoracic cavity. Aspiration can be active or passive. When the patient breathing and coughing, increasing the pressure inside of the thoracic cavity and pushed air to outside. To stopping the reflux of the air to the thoracic cavity, we put in the valve in the end of the tube, and its procedure we call putting the drainage by Bulau methodic. Operative approach we using if all previous measures was not effective. Indications: transformation into the chronic form, that is in case of residual empyema cavity. Volume of the operation: pleurastomy or decortication of the lung. In some cases, when a bronchial fistula and great empyema cavity has been formed, there is the necessity of performance of resection of the lung and corrective thoracoplasty. On this picture you can see the stages of this operation: thoracotomy, rib resection, and putting the drainage to the thoracic cavity, and after that fixing it to the skin. Decortication, it is operation of choice for patients with the chronic form of the empyema, when the around of the lung formation the membrane with the pus and fibrotic tissues, and you have to remove it to control the inflammatory process. Such it looks schematically on this picture. Sometimes we need to perform in a larger flap drainage. Schematically you can look how it looks on this picture. And now I propose you to see a few training videos.
We're going to talk this afternoon about some focal issues, some very specific points regarding complex pleural and parenchymal disease. And it's a pretty small group, so you can stop me whenever something strikes your fancy, you want to have some conversation. I think we have the time to do it, although I have a lot of material. Okay, I thought we would start with classical concepts in CT imaging, specifically differentiation of lung abscess from empyema. Now, why do you need to know the difference? Because the treatment is different. Most empyemas are treated, as you know, with chest tube drainage and antibiotics, whereas lung abscesses generally can get away with just antibiotics alone. So let's look at this slide, which compares abscess and empyema, and presumably you remember most of this for those of you who are doing general radiology, but let's review it nonetheless. An abscess tends to be spherical in shape, has an irregular, non-uniform, thick wall, and very importantly, the normal lung parenchyma approaches this abnormal opacity directly, as opposed to an empyema, which tends to displace the lung, has a lenticular shape, meaning that it's a different size in two orthogonal views, and has a smooth, uniform border. Note that there are occasions that you cannot differentiate the two, and I'll show you a case such as that. So here's a series of lung abscesses, and I like this series because I've collected abscesses over the last 25 years, and this also documents the progress we've made in CT imaging. So the first case you'll see is on an older scanner, and then we have the most newer scanners coming up. So here's a poorly defined opacity in the right mid-lung zone. Very nondescript. You'd probably say it's pneumonia, possibly with the pleural effusion. Here's a nice old CT image that you probably saw 15 or 20 years ago yourselves, and an area of consolidation with liquefaction within. This is clearly a lung abscess with a parapneumonic effusion. Okay, there's a very spherical opacity. And a similar case on a slightly newer piece of equipment shows, again, a liquefied portion of lung, consolidated lung with a small air fluid level. And look, importantly, you have the lung parenchyma, the normal lung parenchyma goes directly to this thing without much displacement. So this should be an abscess, and there's a parapneumonic effusion with it. Here's, again, a newer piece of equipment, consolidated lung, liquefaction necrosis with lots of little air bubbles inside, consolidation right up to this area of abscess formation. Now here's a modern piece of equipment, multi-slice machine. Again, an irregular, thick-walled area of consolidation with liquefaction and air fluid level in, abutting the diaphragm at its lower extent. Again, another lung abscess. And here again, if you look very carefully, the normal lung parenchyma goes exactly to the edge of this abscess. One last set of images is the most recent case. I saw this a couple of months ago. Leukemic patient had a focus of consolidation, anterior segment of the right upper lobe, looked like a pneumonia. We did a CT anyway because he was really running high fevers for a relatively small focal area of pneumonia. Here's the consolidation. There's a little bit of air fluid level in it. There's actually fluid, and you'll see in the next set of images. Here's your collection of fluid. This was a lung abscess. If I go back again, you'll notice that the normal lung parenchyma, again, goes to this focus. Not that there's any issue because it's not even near a pleural space, but there are times that you can use that to make that assessment. Okay, now let's look at some features of pleural fluid. Try to dredge back to medical school days, transudates, exudates, things that you don't think about on an everyday basis if you're doing general radiology. Well, let's talk about transudates. They have intact pleural surfaces, and the problem with how we get the pleural fluid is it's generally either an increase in capillary hydrostatic pressure or a decrease in plasma oncotic pressure, and it usually results either from CHF, renal failure, cirrhosis, things like that. Whereas an exudate results from a damaged pleural surface, causes permeability to protein, and is usually related to either infection or neoplasm. And by the way, the third category, which is not in this thing, but along the green at the bottom, is there are, of course, hemorrhagic effusions, which are due to either neoplasm trauma, dissection, or infarction. When one taps the fluid, one should look at, and that's what the pulmonologist or the thoracic surgeon will do, not your job, but if you want to know about these things, look at the protein, the LDH, and the cytology, of course. Now, let's talk about the evolution of empyema. Well, parapneumonic effusions are effusions associated with infection, be it pneumonia or abscess. They can be simple or complicated. They become complicated when the LDH becomes greater than 1,000, the pH is less than 7.1, or the glucose drops to lower than 40. That's because the bugs are growing in the pleural space. The effusion becomes an empyema by definition when the culture is positive. Now, if you look at the evolution of these effusions from a paraneumonic effusion to a frank empyema. There are three phases. There's an exudative phase, which basically is the inflammation of the visceral pleural surface with accumulation of uninfected fluid. This resolves without any drainage. Basically, you treat the patient when antibiotics goes away, and that's it. There's the fibrinopurulent phase, where bacteria and white cells accumulate on the pleural surface with accumulation of fibrin deposited on the pleura, and you start to get loculations. You're going to need a chest tube to get rid of this infected pleural material. And the last phase is the organized phase, where you have fibroblasts growing along these sheets on the pleura, resulting in fibrosis, lung entrapment, and ultimately fibrothorax. Okay, that needs a decortication to cure this patient. Okay, now, this is an empyema in an early phase. Notice there's a fair amount of fluid in the right pleural space. There's hyperemia and thickening of the right pleural surface. By the way, this patient had a metastatic disease to the spine from breast cancer, and they were trying to make this a unitary diagnosis. Unfortunately, it wasn't. This is not typical of metastatic disease to the pleura, and I'll show you that later on. This is a rather uniform, hyperemic, but uniform pleural surface, not a lobular, nodular pleural surface. Okay, now, here's a challenge case. We got two pleural effusions. Which side, right or left, is the infected side? How many people say right? How many people say left? Okay, the lefts win. The lefts win for a good reason. If you look at the edge, the pleural edge, there's hyperemia here. This is enhancement of the pleural. Look at the other side. This is not enhanced. So this is your infected, this is your empyema side, this is your non-empyema side. Okay, and this is now later on, a different patient, where you start to develop loculations of pleural fluid, and here you're getting entrapment of lung. Now, by the way, there are only a few ways to get air in the pleural space. There's obviously instrumentation, and there's lung laceration, or with a rib, or direct penetration. The other two, there's only two other ways to do it that I know of, and that's a bronchopleural fistula and gas-forming organisms. Most of the time, it's instrumentation, which it was in this case. The other two are quite unusual. Now, this was the case that I had trouble with. The upper aspect of this huge opacity on a plain film had a collection of fluid which was sort of spherical, thick wall on one side, not so much on the other. The normal lung parenchyma extended to the top, to the edge of this thing, and I said, gee, it's probably a lung abscess. But if you go down in the thorax, it was clear that the lower extent conformed to the pleural space with lots of little bubbles inside, hyperemia of the pleura, and there was an empyema. So it's sort of one giant opacity. Of course, there was additional loculations anteriorly next to the heart. And frankly, I said, probably, there's no question it's an empyema. Probably there's a lung abscess too. You're going to give antibiotics either way. You've got to drain the pleural space because you clearly have an empyema. So here's a case I wasn't 100% sure. I sort of read it out as both, but for sure there was an empyema and it required a chest tube drainage. Okay, this is the take-home picture. This is the one you remember when you look at a case. This is an old schematic drawing showing a very smooth lenticular structure displacing lung parenchyma versus an abscess has an irregular spherical lung abscess with the lung parenchyma going to its edge. And here's the correlation with actual images, lenticular empyema versus a lung abscess with an irregular edge to it. Okay, now, you've seen all that stuff. Here's a challenge case. This was sent to me 15 years ago. Someone sent me an outside case. Air fluid level, anteriorly, there's a little bit of pleural fluid. Here's the old outside CT. It is anterior, it's loculated, tiny bit of fluid here. There's a septa in it. Empyema or abscess? Empyema? Abscess. It's a trick question. It's neither. Okay, let me show you why. Here's a chest x-ray from a year before, normal PA. The lateral, the only thing you see is this curvilinear edge, which is a bulla. And so that, and you're right thinking about empyema because a bulla and empyema share many of the same characteristics. They are lenticular in shape, or air fluid levels at differential lengths. They have smooth, uniform inner walls, and they push the lung. And they may have a pseudo-split pleural sign. So they're very similar. To drive that point home, here's the case I just showed you with a little septation. Here's another patient with an empyema that we know. Frankly, they look almost the same. So I saw this case last week, and so I inserted this. So it's not in your handout. I inserted this case because it just came across. I said, just like the other case, except now a modern version of infected bulla, clearly a bulla. It's hard to see, but there's bullous disease on this side as well as on this side. And I said, there's nothing else. There's got to be a pneumonia here, maybe anterior to it, and this is an infected bulla. There was virtually no fluid in the pleural space.
Would you put a chest tube in?
This one? No. Do that, you're in big trouble. You may be in big trouble.
So you have to, it's important to differentiate.
Absolutely. Absolutely. That's a major point. By the way, so here's a high-res CT, and I'm going to get back to that in a second. There is both central lobula, these little holes, as well as paraseptal emphysema, and one of these large cysts became infected. Here's the consolidation next to it. There's a pneumonia, and here's the collection of fluid, and here's the mediastinal windows showing, again, there was really a trace, a smidgen of pleural fluid. So this is how you make that differentiation. Okay, so bulla tend to be present in both lungs, in step-ladder fashion, usually in the upper lobes. So all this fits above the level of fissures. Contralateral lung is important because it helps you make that diagnosis. Both can have strands and septa, so that's not such a differentiating point. But the absence of a big pleural effusion speaks against an empyema. And sometimes the only thing that's going to help you is like that first case, when you have the old chest x-ray showing a bulla there that was there well before anything started up. So you just got to be careful because it's a major mistake to put a chest tube in an infected bulla. Okay, now to finish up infection in the pleural space, we'll go on to organized chronic pleural disease. So despite the presence of extensive fibrosis and maybe calcification, there is a propensity to retain fluid within a pleural space. And this is particularly true in patients with tuberculosis, when one can develop an empyema necessitatis, which is basically an extension of the tuberculous disease through the chest wall, along the paraspinal muscles or along the intercostals, or occasionally develop a bronchopleural fistula. I'll just show you a couple of cases. This was an AIDS patient who had obviously extraparenchymal disease, smooth opacities projecting over the lateral lung surfaces. Here's your lung windows. The lungs are perfectly normal. This is obviously outside of the lungs. Here's your CT image. Two dumbbell-shaped collections of low-density fluid, one within each of the chest walls, which was an empyema necessitatis. And another patient, the same deal, fluid on both sides of the chest wall. This is a cold abscess from tuberculosis. One other weird sort of tuberculous result was this patient who comes in to his internist complaining that he's expectorating chunks of debris. He has his chest x-ray, which shows an air fluid level, which was due to a bronchopleural fistula, and there are some calcified plaques along the lateral pleural surface. And here's a CT. So here's your fluid and air from the BPF, and these calcified plaques started to peel off from the pleura itself and fall into the fluid within the pleural space. Now, the pleural space connected to the bronchi by that BPF, and pieces like this just went into his bronchus, and he just coughed it up. So if you ever hear such a bizarre thing, that's what you're going to expect to see on your CT as a chronic or a fibrothorax due to tuberculosis, which had fluid, became reinfected, and developed a bronchopleural fistula. So again, it's not a common one, but if you should see such a case, that's what you'll expect to see. Okay, next. Okay, now we're changing gears. We're out of pleural fluid infection. Now we're going to go to round atelectasis. And you've probably seen a number of cases, but I've collected a lot of different detail on this particular entity because I was interested in it. First of all, I've collected every name or pseudonym for this entity, which can be called either round or rounded atelectasis. It's probably the easiest to say that. But if you go through the literature, they called it atelectatic pseudotumor, folded lung syndrome. A full name might be atelectatic pulmonary and pleural asbestotic pseudotumor, or AP, or AP cubed. Helical atelectasis, shrinking pleuritis with atelectasis, Bezovsky syndrome, because he described this in the 60s, contracted pleuroceal pleuroma. That's every name I can come up with for this entity. Now, what's the history? In the 50s and 60s, out of the French and German literature, in patients who have had pneumothorax treatment for TB, as well as the South African literature in the 60s, where asbestos workers were noted to have this particular pathology. And it was summed up in 66 by Bezovsky, who found 3 cases of round atelectasis and described its features. Subsequently, about 25 years later almost, in 89, McHugh and AJR described 3 characteristic findings, which are a rounder oval mass about 3 to 7 centimeters near the pleural surface, curved blood vessels and bronchi into it, which They started getting fancy by calling it comet tail sign, vacuum cleaner effect, or if you really want to be poetic, a windswept tree effect, and associated pleural thickening. So this is what was described in '89. Let me show you a bunch of cases and show you some oddball things related to this. Okay, so here's a chest X-ray. There's a vague density down here. The lateral film, it's posterior along a thickened pleural surface. Could be anything. Obviously, lung cancer is in everyone's brain. Here's the scout film. I don't know if it shows any better, but again, there's a round mass. And here's the lesion. It's got calcification, eccentric calcification in it. There's a thickened pleura which shows scattered calcifications. And there's a calcified hilar lymph node. Most likely this patient had tuberculosis, which resulted in all of these findings. If you look at the lung windows, yes, he has some emphysema. And here's that curvilinear blood vessel that gives you that swirl effect, which makes it very characteristic. On the contralateral side, a thickened pleural surface. Note the fatty infiltration, telling you this is chronic, calcifications. And here's your little mass. Notice these little black circles along the outside, seen better on the lung windows. These actually are small bronchioles that remained filled with air when this thing became atelectatic. Maybe not as good a swirl on this, but this is clearly a case of round atelectasis. What do these patients look like clinically? Average age around 60, men more than women because it's more related to asbestos, and most of the asbestos workers are men. Lower lobes most commonly. This is key. Patients are usually asymptomatic, and I'll show you why that's key in a moment. Major causes of pleural thickening to result in round atelectasis. Well, asbestos-related pleural disease, old hemothorax, pneumothorax therapy, tuberculous empyema, and I saw this one this year, 2005, complicated silicosis as an oddball reason to get it. Theories of formation, there are a couple. The only one that makes sense to me is the floating lung theory. Here's a schematic of that. Patient, when normal, develops a pleural effusion for whatever reason. It has been theorized that a cleft forms between the atelectatic and normal lung, and the fluid sneaks into this cleft and organizes in this location. When the rest of the fluid recedes, the normal lung aerates and surrounds this entrapped portion of atelectasis. So that's the theory of how one may get rounded atelectasis. Differential diagnosis, well, clearly lung cancer is probably highest on the list. Obviously, some other neoplasia of the lung. Because of the swirl effect of vessels, one could think about AVM or sequestration, and some non-tissue things such as empyema, hematoma, loculated diffusion are much less likely.
Do you see this more common post-coronary bypass surgery?
I almost never see it post-bypass surgery, unless the patient also has another reason to have had it. Another patient. It's over here. This one was kind of neat because it had a hole in it. But when you look at the lung windows, you can see he has emphysema in his right lower lobe. Well, naturally, he has emphysema in his left lower lobe, and this became engulfed within the atelectasis. And here with high-resolution imaging, I think you get very distinct swirl-like feel, making it a classic case. I was pretty comfortable with round atelectasis until I saw this case. I said, oh boy, now I'm up the creek. Because they reported last year a case of squamous carcinoma in a very classic round atelectasis. And what they said was the case was really classic because there was uniform, even gave contrast yet, uniform contrast enhancement. But they did a bronch for hemoptysis, and that's the key. The patient was not asymptomatic. And so they went ahead and did a bronch. They found malignant cells, and it was a lung cancer. They suggested PET might have proved it was because it should have been cold. It would have been hot. In theory, that would work. Most cases, you don't need it. Okay, this is the actual article showing the uniform enhancement of the pleuroma and a very classic squirrel-like figure. This should have been standard round atelectasis. It wasn't because the patient was symptomatic. One last case along these lines, because it's atypical. Sent to me from the outside, a right middle lung zone lesion. Here's your CT. Notice again the very nice bronchi that are filled with air, this clear thickening of the pleura, fatty infiltration, plaques on the other side. You see it even better here. Look at the asbestos-related plaques. This is a perfect round atelectasis. You even get the swirl, except it's not in the posterior lower lobe. So they felt a little comfortable with this. What they do, they put the patient on an MR scanner, which really didn't help at all. You see the same lesion. These little lucencies, by the way, are theorized to reflect the indentation of thickened portions of the visceral pleura. Doesn't look any different to me than with the CT. So what they do? They stuck a needle into it. Well, how do you manage these things? This schema was drawn up a long time ago, and what we said was, if it's a classic case of round atelectasis, based upon the findings that McHugh described. Then all you need is a follow-up 4 times a year for the first year, twice a year for the next year. If there's no change, the patient's done. If there's a change at any point in time, you're going to biopsy. If the biopsy is negative, you'll continue to follow it. If the biopsy is positive, you'll treat the patient. If the findings are atypical, you're going to biopsy right off. If it's negative, you'll follow it as in the first scheme. If it's positive, you'll treat the patient. So that's pretty much how we work this out. Okay, lung hernia. Now, these are pretty straightforward, but they're kind of cute when you see them. It's defined as a protrusion of lung tissue beyond the confines of the chest wall. They can be classified by location. They can be cervical, thoracic, or diaphragmatic, which is almost never seen diaphragmatic. They can be classified by etiology. They can be congenital or acquired. If they're acquired, they can be pathologic, spontaneous, or traumatic, post-traumatic. Pathophysiology is due to one of a couple of things. In the congenital stage is due to a weakness in the chest wall musculature. In the acquired stage is due to 2 things, one or both, usually both. Diminished chest wall resistance, meaning that the patient had a piece of chest taken out, there was trauma, there was surgery, whatever, and increased intrathoracic pressure. He's a weightlifter, he's playing musical instruments, he's doing a lot of coughing, things like that. Okay, so cervical lung hernias usually occur as a gap between the anterior scalene and sternocleidomastoid muscles. It's an incidental finding, but may pose a problem in a neonate when you want to stick a CBL catheter in, not you, but your colleagues, and occasionally in older patients who have weakening of the endothoracic fascia. Okay, these are the most common. These are the ones that I see maybe 2 or 3 times a year. Okay, the intercostal lung or thoracic lung hernias. They usually due to prior something, chest tube, surgery, stab wound, gunshot wound, whatever, with or without a reason to have increased intrathoracic pressure. They're rarely spontaneous. Diaphragmatic can't really happen if you think about it, because the pressure in the abdomen is going to push abdominal contents into the chest, not the other way around. It's more theoretical. I've never seen a case or even heard of a case, but it's theoretical. Okay, so the first one I ever saw, this is a case from like 20-something years ago, little protrusion of lung cancer. I haven't the foggiest idea what that is. The patient clearly had old trauma. There's some rib distortion, there's some fibrosis in the lung. I had no idea what that was. The guy had a CT a year later for some other reason, because and there was clearly a gap in the chest wall, a little piece of lung sticking through. This is never going to cause this patient a problem. This patient, next patient, however, walks in and said, I have this big mass in the chest wall. I felt it. I said, feels like lung. Let's bring you into the pleura room. Let me see what it looks like. So he obviously had extensive emphysema. Here's a spot film of him doing a Valsalva. So I had him bear down, and his big piece of lung stuck out. I said, okay, but this is an academic place. Let's see, we'll play a little bit. So I brought him to the scanner, and we found a gap in the chest wall. This big bulla was the one that was going in and out. And here I have him without Valsalva and with Valsalva, because I said this is an academic place. We'll play a little bit. He actually had a xenon study for another reason, and this is the posterior view. So this is the right lung. This is the left lung. It's heterogeneous because he had obviously emphysema. And in the washout phase, this was that big bulla that was slipping in and out. And now that I've seen these cases, I now see them all the time. A couple of years later, surgeons came down and said, what's this, we did an aneurysm repair in this patient. What's this chest wall air doing here? Okay, we'll put it on my table. We'll see. Well, you took out 3 ribs in a row. What do you expect? So the lung is going to sneak out. And here's a more modern case. Again, you could see the lungs sneaking out of the right lower chest wall. This one had 2 lung hernias, one posterolateral in this gap, and a larger one anterolateral in that gap. But it turns out I've seen this a couple times a year, so it's not an uncommon finding. You say lung hernia, wow, you see it, but if you look for it, you find it. Okay, so what are the signs and symptoms? If it's that big, you'll feel a mass, crepitant mass increase with cough and Valsalva. This is potential. I've seen quite a few lung hernias. I've never seen incarceration or strangulation. Theoretically could occur with resultant pain and hemoptysis. If you find one, please send it to me. CT can detect it. We get the exact size and site, and we can figure out how to repair them if necessary. Most of them do not have to be repaired. Okay, next topic, and we're doing okay on time. Lung torsion. Now, this is actually very interesting and significant because you're going to save someone's life. If you make this diagnosis, you save this guy's life. If you don't, he'll probably die. What is it? It's the rotation of either the entire lung or a portion of the lung, usually a lobe, around its axis from the hilum. They can occur spontaneously. They can be post-traumatic, and most commonly, they're post-surgical. I'm going to show you the cases I've collected. The the mechanisms are as follows. What increases the propensity to have a rotated lung? Well, if you have a heavy portion of lung, that's going to give you sort of a fulcrum to spin on. If you have a long lobar pedicle, that gives you the ability to make that spin. A complete fissure. Now, if you have an incomplete fissure, the two lobes interdigitate, and that prevents you from making that rotation. If the fissure is complete, it'll spin. You need a place to do it. So you have to have a large pneumothorax or a large volume of pleural fluid. And if you're either torn or you don't have an inferior pulmonary ligament, it allows you to make that swing. What do you see? How are you going to recognize this? Okay, first of all, you look for a place to do it, a big collection of fluid or air in the pleural space, a collapsed lobe that's in an unusual position, hilar displacement in a direction that's inappropriate for the normal atelectasis. You can get a focal change in orientation of vessels or bronchi. You can get bronchial cutoff. Now, this is one that has been reported in the literature. Rapid homogeneous lobar or entire lung opacification. It looks like a big pleural effusion if the whole lung is or a totally atelectatic lung, basically white out of one side. And if you don't make the diagnosis, it'll infarct and probably the patient will die. Okay, so here's the case that I actually got from David Nadich many years ago. Patient had a spontaneous pneumothorax, and this opacity here is actually the atelectatic right upper lobe, but it should have gone, obviously, up and in. It didn't. Here's the atelectatic lung here anteriorly in the wrong spot. Here's a CT showing the atelectasis in the presence of the large pneumothorax. And when they put the chest tube in, the lung detorsed, came back up, and just a little bit of residual atelectasis in the lower portion of the right upper lobe, and the patient basically spontaneously corrected. That's the only one that I saw on a spontaneous basis. But I have seen several on a post-surgical basis, and these are the ones that I want to alert you to. First one I saw, patient had a right upper lobe cancer and a right upper lobectomy. A few days later, he has this AP radiograph, this soft tissue density in the mediastinum. I said, gee, did he bleed? Is there now blood? Is it funny atelectasis? Is it loculated fluid? I have no idea. Let's put him on the table and we'll see what we got. And here was a right middle lobe that's purely atelectatic. But notice the suture line is against the heart. Isn't that strange? And they put the suture line over there. And in fact, as the surgeon said, he put the staple line down along the outside because that's where they cut the lung, and that it flipped in a right-left direction and torsed. He went back in, he got a necrotic middle lobe out. So now I'm smart. I've seen this case. A couple of years later, I see this case. Same story. Right upper lobe cancer, right upper lobectomy. 3 days later, I see this density up at the apex. I said, well, it could be loculated fluid, it could be blood, but I wouldn't be at all shocked if this is a torsed middle lobe again. So I told him, let's get him on a table. A little bit of air in the pleural space. Here's where they amputated the right upper lobe bronchus. This is the atelectatic middle lobe. Here's it on mediastinal windows. And the surgeon said, this can't be that. There's no way. I put staples all the way around so this couldn't happen. I said, okay, but that's what I see. On the next cut, here's the middle lobe orifice amputated right here because it's a tight rotation around that axis. He went back to the OR, and the surgeon told me, he wouldn't give me the satisfaction telling me it was a middle lobe torsion. He said it was a venous infarct because of, it was a little bit of a torsion with a venous infarct. It didn't cut the arterial supply. Okay, fine. He took out the middle lobe, and that solved the problem. Last year, I saw same story. Patient with a right upper lobe tumor, right upper lobectomy. I see the same density. I said, no, now I'm smart. I can be a genius. I seen this one. I said, this is going to be an upper lobe, middle lobe rotation. And sure enough, this is the middle lobe, which is consolidated. They also tried to staple it like crazy to prevent it from rotating. Here's the middle lobe orifice, which stops abruptly over here. And this one, in fact, they admitted that the patient did have a rotation of the middle lobe. And here again is the consolidation. So now you can be smart like me, and we can all make that diagnosis. Now, we're going to move to tumors in the last 15 minutes, and I think we can do that in under 15 minutes, so we'll get you out on time. Starting with benign tumors. These are clearly uncommon, although I've seen a number of pleural lipomas, and it's very easy to depict. There's no sweat with that. Nobody has any problem making that diagnosis. This is a pleural lipoma, which you couldn't make it on plain films, although if you've seen enough of them, you say, gee, it looks like a pleural thing that doesn't look too important. Here's on CT a very nice lipoma. I've seen them dumbbells. Some of them go across the chest wall. It's not an issue for anybody in this room. Now, this one, however, is more problematic. Localized fibrous tumors of the pleura. These can be very small. I've seen a couple of like 2-3 millimeters within the fissure, so huge lesions occupying most of the pleural cavity. They have no relationship to asbestos exposure. They're later in life. Usually they are generally asymptomatic, and if they're symptomatic, they may have some chest pain, shortness of breath, or a couple other symptoms that you see here in front of you. They more often affect the visceral rather than parietal pleura. They can be pedunculated. That's where they're really neat to have an example of it. And so they move around. And what's another point that's very important is they tend to be homogeneous, particularly when you inject them. And if it's not, then think about something else. Pleural fluid is very uncommon. So here's a soft tissue mass in the left lower lobe. Obviously, you couldn't tell what it is based upon plain film radiography. Well, frankly, you can't tell what it is on CT imaging either. You have a rather homogeneous mass next to the aorta. You can't make that diagnosis. This one, however, was more interesting. X-rays 2 different times. Here it's medially in the thorax. Here it's laterally in the thorax. Here it's anteriorly. Here it's posteriorly. So you know it's got to be on a pedicle. So this thing is moving around. I think you can make a diagnosis on plain film over here, pretty much, because nothing else is going to roll around the chest like that, unless you have an aspergilloma in a cavity, but obviously that's not that. Here it is on CT, when it's in its anterior location, because that's the diaphragm over here. Rather homogeneous enhancement of this mass. And I think that's really important, because I showed you the next case. I saw this case last year, and I said, oh, I can be smart, cool. This is a benign fibrous mesothelioma, an asymptomatic young woman. And I said, no problem. Well, we put it on a table, and it's very heterogeneous. I said, oops, I don't know, I can call it that anymore. So I said, gee, I don't know what this is. You better either do a biopsy or take it out. Turns out it was a schwannoma. I don't think anyone could make that specific diagnosis. But the point is, it's not a benign fibrous mesothelioma because it doesn't have the right enhancement characteristics. Okay, now we'll do malignant pleural disease. Okay, obviously there are primary and secondary forms. The secondary ones are most commonly from lung or breast, particularly if they're unilateral. If they're bilateral, then obviously other things to include are adenocarcinoma of unknown origin, melanoma, lymphoma, or invasive thymoma. And differentiation based upon for specific histology is not usually possible, but the pattern is helpful and can help you make a diagnosis, and I'll show you that in a few moments. Okay, so what are we looking at? We're looking at large bloody pleural effusions which have focal, diffuse, or circumferential nodular thickening of the pleura, usually greater than a centimeter, with enhancement. Okay, so how do we differentiate benign from malignant? This is a classic benign, sort of uniform, smooth thickening of the pleura. This is a more nodular-looking, and I'll show you much better examples, enhancement of the pleural surface. This is malignant, that's benign. Okay, so here's a typical case. You come in as a large unilateral effusion. Here's your CT image, and this is very classic. I mean, there's nothing else this can be but malignant pleural disease. This nodular, enhancing, thickened, lumpy-looking pleura. This is a lung cancer, which would make sense because it is in fact unilateral. There's another lung cancer on the contralateral side. Again, nodular thickening of the pleura, and a little lower down, here's your lung cancer. Small effusion, but lots of nodular enhancement. There's also probably a met in the contralateral lung. This is a small cell lung cancer with extensive nodal disease in the mediastinum and in the hilum, and a decent size effusion. A little lower down, you can see the nodular enhancing pleura. Now you look at this, and this pattern is entirely different. What's the diagnosis on this? What's the primary, would you say? Challenge case. What's that? Someone else said something else. It's got axillary nodes, destruction of the sternum, and malignant pleural disease. I'm going to call that breast cancer every day. That's breast. This is a breast cancer because that's the pattern. If you think about the pattern, what's a drainage? So it's going to hit here, it's going to hit here. It makes the most sense. In fact, it's breast. I looked at this case. It was predictated by one of our residents earlier this year. Said it was normal. I said, I don't think so. I said, first of all, at the very least, it's a mastectomy. Here's the left breast. There's no right breast. There's no height. I said, in addition, I said, I don't like the way this looks. Patient came in with chest discomfort. I said, there's something in here. I don't like this. CT, it's very obvious. So there's a big mass in the medial aspect of the breast. It goes right through to the mediastinum. And if you look at the pleural surface, there's all these little nodular thickenings and a small effusion. So she had a lot of reason to have chest wall discomfort, not to mention the metastasis to the sternum. So again, the pattern is very helpful if you think about it, and you don't have the history. Sometimes you read in vacuums and you say, what is this all about? And you have no idea, but if you look at the pattern, it'll help you. Another patient with breast cancer who has metastatic disease to both the visceral and parietal pleura with a spontaneous pneumothorax. This patient was jumping around, but understandable. Had a large soft tissue mass in the left mediastinum, some pleural disease over here, thickening, lobular thickening of the pleura both sides all around, as well as a lesion at and below the diaphragm with a lesion in the spine. This is a malignant thymoma. Similarly, here's the chest x-ray on a different malignant thymoma with masses along the pleural surface. Here you see them up at the apex, medially, laterally, next to the heart. Okay, now this case was last week. I said I'm going to bring this case because I like this case. This guy had a big pleural effusion, and he didn't have it three months ago. And I'll show you the lung windows first. And I looked at these cavitary and non-cavitary nodules. Some of them were poorly marginated, fuzzy, different stages of evolution. I'm thinking maybe it's septic emboli, maybe it's invasive aspergillus, depending upon the story. And I looked at the pleural space and I said, there's nothing but. This is malignant pleural disease. This has to be, those have to be cavitary metastases. So where do cavitary metastases come from? They usually have squamous origin. Usually if it's a female, it's female cervix. If it's a male, it's this cervix up at the neck. And it was a head and neck tumor. It was a carcinoma of the base of the tongue, which usually is locally aggressive, not systemic. But this one clearly has cavitary mets and, in my mind, nothing but malignant pleural disease. Okay. Moving to the last component, which is mesothelioma. That's the most common primary lesion of the pleura. It's a couple thousand cases a year, usually older people, men more than women, because obviously, again, they work with asbestos, which has a nice association, usually a long time after exposure, not really associated with smoking, and has an insidious onset set of symptomatology. Diagnosis is made usually by VATS or open surgical biopsy. Here's a poor prognosis, and one could try a extrapleural pneumonectomy, not usually very successful. What do these look like? Now, here's the key on separating out malignant pleural disease primary from malignant pleural disease secondary. This works a good chunk of the time. Which side is bigger? The right side. Which side is abnormal? The left side. So there's volume contraction on the left side. And I've seen that with malignant mesotheliomas more often than not, that there's volume contraction on the ipsilateral side. So here's your nodular pleural thickening, which for all the world looks like a lung cancer met to the pleura. There's nodal disease in the mediastinum, nodal disease in the hilum. This certainly could have been a lung cancer, but there's a small left hemithorax. I would vote for mesothelioma. Similarly, next case. Now it's on the other side. The small side's the right side's the bad side. In this case, this could have been a lung cancer, but it was malignant mesothelioma. Again, volume contraction versus volume expansion. And this is the last images I'm going to show you before some summary things. Again, a very thick pleural surface, including the fissure. Again, the small side's the right side's the bad side. This should be mesothelioma rather than lung cancer. This is MR imaging, nicely depicting the extensive pleural disease, including fissural disease, present within the thorax. So, differentiation of the specific diagnosis is often not possible based upon the CT assessment of the pleural alone, but that if you use the pattern, that is, look at this axillary, look at this sternal, see if there's volume contraction or volume expansion, that's going to help you make the specific diagnosis in trying to differentiate which kind of malignant disease. In isolation, you're not going to make it. You have to use everything that's on the film.
My name is Dr. Navin Ramachandran. I'm one of the clinical teaching fellows here. I've been asked to examine your chest and a few other parts of your body to determine how well your lungs are working. Is that okay?
That's fine.
Brilliant. Would you be able to just lie back? Yeah, that'd be great. I'm just going to step back for a second and take a look around. Okay, could you take a deep breath in and out for me? And could you cough for me? Excellent. Do you have any pain anywhere at all?
No.
Could you hold your hands out for me? I'm just going to have a quick look at them. Just flip them over. Again, hold them out straight again. Could you cock your wrist back for me? Ideally, I like to do this for up to 1 minute to look for a flattening tremor. Brilliant. You can rest that arm down. And you can rest this hand as well. check for up to 30 seconds to work out the respiratory rate. Rest your hand down. Would you be able to look up at the ceiling for me? Just going to pull your eyelid down. Have a look. Brilliant. Could you open your mouth for me? Now stick your tongue to the roof of your mouth. Brilliant. Great. Could you look over that way for me and rest your head back? I'll take the weight. Excellent. And could you look straight ahead? I'm just going to lay my hand on your neck. If it's at all uncomfortable, let me know. Okay. Excellent. You take a deep breath in and out. And out. And again. And out. I'm just going to tap on your shoulder and your chest. Now I'm going to listen over your chest. If you could take a deep breath in and out each time I move my stethoscope through your mouth. And if you could say 99 every time I move my stethoscope.
99, 99, 99, 99, 99, 99, 99.
Brilliant. Would you be able to sit forward for 1 second? I'm just again going to feel your neck. I'm just going to be looking for any swollen glands. So if it's again uncomfortable, let me know. Deep breath in and out. And again. Again, I'm going to tap on your back, if that's okay. And again, if you could take a deep breath in and out every time I move my stethoscope with your mouth open, through your mouth. Say 99 now every time I move my stethoscope.
99, 99, 99, 99, 99, 99.
Do you have any pain at all in your back?
No.
Okay, I'm just going to push in at the bottom now. Okay, lie back now. Do you have any pain at all in your legs?
No.
I'm just going to push in there. Thank you very much.
Okay.
Thank you for your attention and good luck.